Welcome back, everyone. As Rafe mentioned, we're on a timeline and we're sticking to it. So it's my pleasure to introduce our next speaker, Roger Bedimo, who's a professor of medicine and the interim director, Office of Global Health at UT Southwestern Medical Center, chief of infectious diseases at the VA North Texas Health Care System. His research interests include the analysis of rates and mechanisms of chronic complications of HIV disease and antiretroviral therapy, as well as the contribution of HCV co-infection on HIV-associated morbidity. And if you've ever had the pleasure of attending one of his talks in the past, you know that you're in store for a action-packed talk with lots of learning. So over to you.
Thank you so much for this kind introduction. And we are off Broadway, so there will be no acting. I'm just going to get you through what was presented at CROI, and a very vibrant meeting. It was part revival, part group therapy, and part science. And all of us who are into this business feel the need to be together, reinforce each other's confidence, and make sure we deliver an unequivocal message to the people with HIV and at risk for HIV that we stand for them. So here we go. These are my disclosures. And what we would like to achieve today is describe notable abstracts that were presented at CROI, summarize recent advances in prevention management and long-term complications of HIV presented at CROI, and describe recent findings on HIV persistence and cure and the implications for cure agenda. And then we'll summarize key findings on OIs as well as COVID-19. So we are going to go through these 5 different bullets. If you work for the federal government, for me, you're very familiar with 5 bullets of what you did last week. So we're going to go through the progress towards ending the HIV epidemic. Are we really on track? And then management of naive and experienced patients, and then prevention and management of OIs. And then we will touch a little bit on HIV cure and how challenging it is, as well as COVID-19. So first part, progress towards ending the HIV epidemic. It was not very far ago, not very long ago, that this very visionary program was set in motion. It had 4 pillars that were supposed to lead us towards ending the HIV epidemic as we know it. I will focus on the 3rd pillar, the one in yellow, prevent new transmissions by using proven interventions and including pre-exposure prophylaxis and sharing programs. It is under attack now. We have headwinds. We don't believe in that anymore. So we need to make sure we reinforce that this has actually been highly effective. And this is where we are in terms of progress towards ending the HIV epidemic. Neutral. And this is one of several modeling data and summary data that were presented at CROI. This one specifically I like because it shows you how HIV incidence has changed from 2013 at the bottom to 2023 at the top in different epidemiological prevention trials and others. It has not. So the incidence of HIV remains alarmingly high. We have hotspots like Latin America, Eastern Asia, Eastern Europe, that we need to be focusing on because we're not making progress, not because of lack of tools. We're getting better and better tools. And this is one of the tools, the newer tools that are going to be available for us. Is the PK and safety of once yearly formulations of lenacapavir. Last time we encountered this drug, I was in Munich in July, where the purpose studies were presented showing a significant efficacy of subcutaneous injections every 6 months to prevent HIV. Now, we have an inkling on what that can be if we moved on to yearly administrations, not subcutaneously, but IM, of 2 different formulations with 5% or 10% ethanol. These pharmacokinetic studies suggest, I'm just presenting one of the 2 formulations, but they were nearly identical in the fact that the levels achieved were equal or superior to the one that were achieved for every 6 months of lenacapavir subcutaneously. And what I'd like to pause here to say, we talked a lot about PrEP, how efficacious some interventions are in terms of clinical trials and even short follow-up studies. But what we need to understand is that remaining on PrEP is incredibly hard. And all the studies will show you that after a year, after 2 years, very few people actually remain on PrEP. So we need to make sure, as we introduce new tools, that these are tools that prepare people for staying on PrEP for the longest duration. So this is hopefully one such tool. And you can see that the concentrations that we achieve for all patients in the once yearly were either at or above those achieved for Q6 months subcutaneous injections, which already we did have some concerns with the nodules, and the data that we presented were not long enough for us to be confident. That was less than a year worth of data. Now, even more tools, this is an NRTTI, so nucleoside reverse transcriptase translocator inhibitors like islatravir, and MK-8527, looking at the PK/PD threshold and phase 2 dose selection for mostly oral HIV pre-exposure prophylaxis. This study was done on rhesus monkeys, and what was given here is a range in doses from 0.1 to 6 milligrams intrarectally every week for 12 consecutive weeks at PrEP. Now, you will appreciate here that the monkeys that receive PrEP, 0 out of 8 animals were infected at each dose level. So they were all very efficacious, while 5 out of 8 animals and 7 out of 8 for 0 milligrams, that is the vehicle alone or control, were infected. So very promising. So the doses of MK-8527, 3, 6, and 12 milligrams Q monthly were selected for phase 2 safety and tolerability. So I repeat, this NRTTI called MK-8527 at doses ranging from 0.1 to 6 milligrams per kilogram were highly protective in this model. So we also have talked a lot about PEP in the past 2 talks, fantastic talks, and showing you that not only did post-exposure prophylaxis doxycycline work in studies, now we're showing that it actually does work in real life experience. This is Kaiser Permanente. There were other studies of the sort that were published lately showing you how dramatically adoption of PEP would decrease the incidence of chlamydia and syphilis. Now, GC was a little more nuanced. So among doxy-PrEP recipients, your quarterly chlamydia positivity decreased by 80% in this study. Now, again, this study was presented to you earlier. That was just published last week. As a word of caution of increased resistance with use of PEP. I just put it as a preamble to what was presented at CROI, antimicrobial resistance of and gonorrhea at community-based sexual clinic from 2023 to 2024 what is interesting here is that these individuals on HIV pre-exposure prophylaxis with a history of STI reporting a moderate or high number of sexual partners and engaging with sex with a nominal of partners. So these were high-risk individuals. You will see that all non-steroidal gonorrhea isolates were susceptible still to ceftriaxone, but only 10% were PAM susceptible. So heavily, high-risk populations who are taking post-exposure prophylaxis will eventually have GC isolates that are resistant to a number of drugs. So, and 60% resistant to Cipro, 33% resistant to tetracycline. But PAM susceptible, only 10%. And so that is important. And again, I'm glad this was covered in the previous talk, and there were some questions that were answered. But so this is one of the things that we need to be aware of. The second portion of our talk is progress in managing antiretroviral naive and experienced participant. The first part is 2 is the new 3. And we will see, and then we'll look at the further in the new capsid, and another INSTI Gen Z, so new generation INSTI. And then we will look at getting very pro-antibiotics, antibodies. So first is a single tablet antiretroviral therapy with doravirine, islatravir, which are shown to be effective in maintaining HIV viral suppression. 2 studies, sister studies, 204A and 204B abstracts. I will present 204B first because it makes 2 points. These are people who receive open-label doravirine islatravir versus continuing baseline ART. And this is an illegal study because it has diversity. It has blacks, it got females, it may even have MSM. I don't know what they were thinking. So that study looked at this, and then it showed, lo and behold, that diversity is good. And so we had a single tablet such as was highly efficacious in maintaining virologic suppression. But again, I started with 204B because it made 2 points. 2 concerns in such a study. Concern number 1, lymphocytes. Concern number 2, does this drug make me fat? Okay, so, and concern number 1, it's a lymphocyte. It's a total lymphocyte count did not change. There was a similar curve for CD4 count, which also did not change. But on the left, you see that the only people in whom there was some increase in weight were people who were receiving 2 drugs that have now been shown to be weight-suppressing drugs, TDF, efavirenz. So forget Ozempic, take TDF. And so that's what it is. And then 204A made the similar thing. Now this was a double-blind, not open-label, doravirine, and people switched from bictegravir, FTC staff, not from everything else. Again, it showed that this regimen was highly efficacious. And identical rates of discontinuation for protocol-specified total lymphocyte count and or CD4 counts. Again, lowering that dose of islatravir have been shown now to be safe in these 2 sister studies. And so I think that it will be an option to move forward with. So proof of concept trial of an oral VH499, again, that's the new feather in the capsid, and new capsid inhibitor. And this is a new capsid inhibitor in development as long-acting antiviral for treatment and prevention. Again, we keep getting longer and longer, and I think that if I look at my crystal ball, which I left in Dallas, it shows that we will probably soon have yearly options, both for treatment and prevention, and that would be a very a new time in HIV treatment. Now, this is a phase 2A study looking at different doses from 25 milligrams to 250 milligrams of that a new capsid inhibitor. And this is what you like to see, which is somewhat of a dose-response curve. Greater exposure equaled higher viral load decline. to not too shabby minus 2.2 log copies per ml for the highest dose, which is 250 milligrams. And so no trend observed in the types of adverse events, and no adverse event leading to withdrawal. So there were no clinically relevant changes in laboratory parameters. So this is looking good, and now we may have not just one, but two promising agents in the capsid inhibitor class. Another study that shows also reassuring dose response curve is VH184, which is a third generation INSTI. In 3 doses, 10 milligrams, 50, and 300 milligrams, taken once every 3 days, and monotherapy in 22 ARV naive people. And again, not too shabby, minus 2.69 log 10 decline in viral load observed in the highest dose, the 300 milligrams. So no drug resistance mutations observed yet. And all side effects were mild or moderate, and no serious side effects leading to discontinuation. So we have newer tools, and even more newer tools are coming. So if HIV prevention doesn't become illegal, it will get better. So that's the, and then now let's look at the antibodies, so the so-called N6LS, efficacy and safety, and this study called the EMBRACE study. And this is a broadly neutralizing antibody. It's a binding, the CD4 binding site. And then in phase 1, single dose, IV, 60 milligrams per kilo, and subcutaneously 3,000 milligrams showed good safety profile. And on phase 2B, the primary endpoint was plasma viral load greater than 50 at 6 months. And then you can see on the right, that you have the IM dose. The sub-Q dose was paired with this compound called RHU-PH20, a hyaluronidase, to break down the sub-Q tissues to allow for great exposure of the drug. And then you have the oral standard of care. And you can see here that this was, if my memory serves me right, for broadly neutralizing antibodies, you have to test for susceptibility at the baseline. I believe it was 3/4 or 80% of people that were tested had it. So Q4 months monthly with Q4 month with monthly cabotegravir LA. One of the questions you can imagine that came after this presentation: why didn't you try with Q2 months cabotegravir LA? And then to resistance detected in both participants who had confirmed virologic failure, and one INSTI RAM detected in one, and of the 2 participants with confirmed virologic failure in the standard of care group. So it was well tolerated. And then moving forward, it will be N6LS Q6 month with cabotegravir LA. So we will see if this will become yet another tool in our armamentarium. Then the RIO trial, which is a randomized placebo-controlled study of 2 broadly neutralizing antibodies that we've seen before, 3BNC117 and 1074, double-blind randomized controlled trial investigating maintenance of viral control in the absence of ART with these broadly neutralizing antibodies. So the idea remains that if you find an intervention, whether it's a therapeutic vaccine, an antibody, or something else, that will allow us at long last to be able to interrupt antiretroviral therapy, we will have made some progress. So here the viral load rebound is not what we used to in the typical ART studies, because it's a little more permissive. So these were 6 consecutive HIV RNA of more than 1,000, or 2 or more than 100,000. And then there were no baseline resistance in the majority, 63 to 68. You see on the right the schema of the study. The second blinded dose that was optional. That's why you see the asterisks after the primary endpoint. So we'll still result in the primary endpoint, and what happens after that time. So you can see here that it's really clear that that strategy reduced the likelihood of viral rebound at that week 20 significantly, i.e. the departure from between the blue and the red curve. And that continued to some extent after the 20 weeks, and then you see that 57% had not rebounded at week 48, and 39 had not rebounded at week 72. But just as a word of caution, as you see a lot of people out there on antiretroviral therapy, some of them will actually not rebound if you stop. You just don't know which one. Now, the so-called SMART study wasn't so smart several years ago because we know this is not something to try at home to stop. But you can see here that 2 out of 34 of those who were in placebo, when they stopped, they didn't rebound. So that does exist. We'll return to this concept towards the end of the talk when we talk about viral persistence. It gets a little more nuanced, but we get any more insight into how HIV hides and why we can't get rid of it, and that's important to understand as we move to cure strategies. So sustained viral suppression after this BNAB dosing was associated with enhanced GAG-specific T-cell responses, consistent with an immunologically driven method, which is what we wanted to see in this particular study. So now let's look at the prevention and management of OIs. We're falling short in screening for syphilis, and that is important. And the second portion was, I will let my dear friend and colleague, Dr. Thompson, talk about HBV vaccine prevention because it's really good news. And then we'll conclude with short course TB therapy in people who are pregnant. So now, first of all, we all know that if somebody comes to the ED and they have chlamydia or gonorrhea, what do? We test for all other STIs, including syphilis and HIV. That's good. We should always do that, even if sometimes we don't. But even when we do that, we probably miss up to 3/4 of cases of syphilis by just waiting for someone to show up with GC or chlamydia or something else before we take the so-called targeted testing. I just want to focus on what is in red. If we did that, which is something we should always do, we will only identify 24% of the syphilis. If you remember several years ago, we finally figured out that if you only test one site for STI, you're missing 80% of GCs. So hence the 3-site testing. I think this is such a seminal event. We need to think how we're going to identify syphilis in the future. So these 2 studies we're going to see by Dr. Thompson. And so I'm just going to tell you briefly that prevention of hepatitis B with the newer vaccine, the so-called CP-8B CPG, has gotten a lot more efficacious, both for people who failed the alum-based vaccines and people who had never taken it. So I wanted to take these 2 slides off because Dr. Thompson will expand on this even more because if you see that duration with a CPG-based vaccine is actually highly durable. Another thing we learned is that if your immune response is very high, like over 1,000 international units at the end of the vaccination, it's highly predictive of sustained protection. So dolphin moms is a study. If you live in some areas, especially where TB is very prevalent and co-infection with HIV is very prevalent, it's important to get TB prevention with 1 HPE or everyday rapamycin and INH, or 3 HPE every week for 12 weeks. But there were concerns about what that would do to the PK of dolutegravir. And this is a study looking at PK of dolutegravir with HIV virus suppression in 1 HP or 3 HP pregnant Homo sapiens. So we see that this DTG dosing was considered acceptable if the 5th percentile of DTG troughs is over that middle dotted line, 158. And that was highly surpassed by both strategies. So the simulations predict that once daily dosing will achieve target dolutegravir that were reasonable and with 3 HP, but not for 1 HP. So what we see here is that if you take dolutegravir every day for, ionisaphopentin every day for 1 month, it's as good as ionisaphopentin weekly for 3 months. But in the case where you're getting DTG once daily, the 1 HP was not something that they would recommend. So it's important to make the distinction. So we'll finish here with persistence, and then we'll talk a little bit about COVID, just one slide. So ART actually does work, and we learn that all the time. Looking at, for instance, you see some people after prolonged viral suppression still have every now and then detectable viremia. The good news is that the large majority of that viremia is defective virus, especially in this position, 5' leader defect viruses. So they're there, they make us feel bad, and the people with HIV concerned, but a lot of the times they're not really viruses that would replicate. And so that's important to know what type of virus we're detecting in somebody who's vascularly suppressed. But, and that is what you see here, that these viruses that contributed to non-suppressed viremia were highly clonal, was the same. So that means that it's not ongoing replication will stop. It is clonality that is spewing at virus, and that virus, a lot of it is defective. And I will move on to show you that what we have thought for a while is that HIV does integrate, and in some cells that are dormant, resting CD4 cells, is kind of camouflaged and the immune system doesn't see it. That's why it persists, but that's not true. Recent studies suggest that there's actually, an ICU telltale sign from the immune system that is seeing that virus, but that virus is figuring out ways to still persist even as it's being detected by the immune system. By doing a number of things, it has integrated in some interesting sites at the centromere and the zinc finger, or so-called gene desert. But also, there is transcriptional patterns of that virus that suggest that it has made some changes. At the same time, we see phenotypic markers of the immune cells that are supposed to fight that virus that are changing to suggest that they are also responding to that virus being present there. And this is a very elegant study that was done looking at the top at phenotypic and provirus sequencing over 20 years. And at the bottom, looking at what the PBMCs are showing in terms of the immune effector and phenotypic profiling of our immune cells over those 20 years compared to elite controllers and HIV negative. The bottom line is that there is a modulation of our immune system to try to change in response to that virus that is hiding there, but that they can't quite get rid of. These things suggest to us that it's not really a sanctuary, but that we're seeing it and we are doing our best to get rid of it, but we can't. So in terms of COVID, this is a drug that we last encountered a couple of years ago at CROI because it showed not just decrease in symptoms, but also probably decreasing the risk of post-acute sequelae of COVID. What was presented at this CROI is that it may also be effective in preventing COVID in household contacts of people who have been recently infected. And this is important. by 2/3, it looks like, because the risk ratio was 0.33. Because there are some people who are left behind in COVID, those who will not respond to the vaccine owing to the immune dysfunction. And so these are people that we need to have other measures to prevent COVID in them. So that's sort of, I hope that we went through sort of a whirlwind on prevention tools, management of treatment naive and treatment experience, as well as the cure progress, and then some insight on new COVID management. So thank you for your attention. Oh.
Well, thanks. And thank you for summarizing some of the presentations at CROI that I didn't get to. That was fantastic. We have a couple minutes for Q&A. If you're collecting questions, you can also ask about stuff at CROI that maybe wasn't presented. And I'll start with a question. So if we find that doravirine islatravir moves forward and turns out to be a good agent, how do you envision incorporating it into sort of treatment of people living with HIV, given what we already have now?
Yeah, so the main thing, because we have had two paradigm shifts in HIV care that we have probably not appreciated enough. One is two-drug therapy. Now, I don't think there is any new treatment options being looked at out there that contains more than 2 drugs. So this is where we headed, this is where we are now. And so the second paradigm shift being from oral to non-oral, as well as from daily to non-daily. This particular option, I did not, again, count me among people who didn't think that injectable options were preferred by many. But again, less than daily options may end up, less than daily oral options may end up being preferred to the current injectable options, I think so. And the caveat that we're gonna need to think about a lot is that a lot of these dual regimens, oral or otherwise, do not contain hepatitis B active drugs. So now we need to always think about that, especially in people who switch away from Hep B active drugs.
Okay, thanks. Well, we have one question. What is the best way to counsel patients about GC resistance data on Doxy-PEP? I bet you wish that was asked previously.
Yeah, so essentially, PEP works, but there are caveats. I think the study that Dr. Blair presented earlier suggests that the more PEP you use, the more likely that Doxy resistance will be. But again, you know, it's a understanding that, you know, what would be the lesser what would be the lesser evil? You know, we looking at the Kaiser Permanente and other studies and San Francisco data, by the way, suggests that Doxy-PEP is really, really effective, you know, on the population level. So if you look at that, and you have to be willing to accept some costs, I don't know how much, and we still don't know what the implications of this resistance, growth of resistance will be, which they were already growing in Asia. We already were seeing a lot of GC resistance coming to us from Asia, so it's just gonna accelerate, I think.
I think there was a question earlier about the time, how long it takes to really see broad resistance in a population. So this may also be early days.
Maybe early days, yeah. Yeah. No, I think I really like that question because I always thought syphilis was the dumbest bug we ever had. Because, I mean, we've been treating that drug with penicillin for what, 70, 80 years? It hasn't figured it out. So it may not figure out other drugs than azithromycin later, but GC is different. GC will figure things out quite quickly. So I think we have a different problem.
Okay, so there seem to be some PK outliers in the TB data. Were there any treatment failures? And we have a little diagram in the back of the card, if you don't remember.
Yes,
Do you know if there were treatment failures?
Well, yeah, so the dots at the bottom were outliers. And now these are very small studies, so a few outlier dots there are concerning, even if it's so the 1 HP did not have enough confidence that it will get us above that second dotted line of 158 level, which is a pre-specified dotted line. And so that is why it was thought that the 3 HP would be better in a pregnant person who is going to take DTG-based regimen. I hope that answers the questions. If not, I'll be happy to expand more.
Okay. So it's great to hear that patients with low-level viremia have ineffective viruses circulating, but how do you know and how do you counsel patients?
Oh, this is a difficult question. Sometimes I feel the provider needs counseling because whenever, we see a virus, we go out open a tizzy, but it's thanks to, my good mentor sitting in front here that we had some threshold that have been lowered from detectabilities from less than 500 copies to now less than 20 to now target not detected and nothing. But these all suggest that there is usually a threshold in our clinical assays. Half the people that we see with viremia of less than 20 have some viremia in single copy assays. But, so that's the one thing. So we're not seeing it, so we're happy. But there is also some people, according to that study presented at CROI, who have what they call NSV, non-suppressed viremia. And usually, actually, those were people who have been undetectable for years and years, and then have some viremia. And those give us a lot of headache. And the participant is, the person with HIV is worried that maybe they were not adherent. The provider is accusing them of not being adherent. But it's important to note that a lot of these people, it's not, number one, what the study suggested is that it's not that the viral replication is ongoing. It has stopped. It's this clonal expansion. And number two, that clonal expansion is mostly defective viruses. So those two things make us more comfortable, and that's sort of as much as I can convey that to the patient, I will.
Okay, well, we have one more minute and one last question. Lenacapavir Q6 months plus cabotegravir, any comments? And I assume that's for treatment.
Yeah, I've been very pleasantly surprised that as of late, drug companies get together and take their drugs to the dance together, because we still need two to tango. And if there is dosing parity, it makes sense, especially if the mechanism of action is very different. Now, but beyond that, I can't comment.
So I believe that Gilead may have other plans for different agents to pair with lenacapavir, but I do know that people are combining those two agents clinically in some situations. You say, yeah. Okay.
I mean, HIV providers are nothing if not mavericks. We write guidelines, they don't wait for those.
Great. Okay, perfect timing. Thank you very much. And